So I'm guessing you also got the introduction bio from Andy.
Yeah.
Hello, Kamal.
Kamal, you're talking to yourself. You're on mute.
Oh, sorry. Uh, Good evening, good morning.
Good morning.
I'm still at hospital. We'll be listening from here.
Oh, good. So we have a good participant turnout already, and then we haven't even reached the time yet. So
I think we have 1 more minute.
yeah.
And my team is joining only from my login.
Oh, okay.
Well, the main question is Andy Beck here?
Yeah.
Is Andy available or not?
Rami, you may have to reach out to Andy because
I did. I just texted him.
yeah. Let's see.
So is Andy back? Is Andy available?
Yeah, he's here now, I think.
Okay, great.
Hi, Andy.
Hey, Ramu. How are you?
Very good. How are you?
Good. Hi, everybody.
Hello, Andy.
Andy, we'll give everyone like 3-4 minutes to join as people are joining in, and we'll start. But we should make sure we can test your slides can be shared.
No problem. Yes, let me pull them. Let me get them loaded up here and we'll get it set to go. All right, Ramu, I'm ready to test them whenever you are.
Yeah, you can go ahead. Let me stop sharing my screen.
All right. Is that working for you?
Yeah, we can see it now.
Nice. That's a
Oh, what a
fantastic.
Nepali. Who provided you this picture?
That's a Nepali AI grandfather.
Oh.
It's a nice photo.
The wrinkles in his face doesn't look natural.
Came directly from Dr. Adhikari.
Yeah, this is from my.
He's not the snake.
Yeah, he's not quite dyspneic enough.
Yeah.
It looks a little too calm.
Andy, you can stop sharing now. We'll share the introduction slides.
Sounds good.
Yeah, we already got 37 and I have 4 people with me. We
Okay,
already got
so I think that's a
30.
decent number. You think, Rama, we can probably go ahead and start the introduction because there's already a decent turnout.
I think
Yeah.
so. Yeah.
Okay, hello everyone, namaste, and thanks for joining us from your computer, mobile phone, wherever you are right now. And it's morning time here in the United States, and it's evening time there in Nepal. So thank you for taking the time. This is a continuation of a discussion series that we have been doing for a while, and then I'm glad to say that now we have joined HAPSA and HAPSA Nepal, and we'll be doing this through HAPSA Nepal. And the topic today is going to be an approach to acute dyspnea, and we're especially focusing on pulmonary embolism. The special feature of this series is that we discuss important emergency medicine and critical care topics, and we try to focus them on resource-limited settings or specific to the practice situation in Nepal, and we try to bring everyone from Nepal into the discussion as well. Today, Dr. Andrew Beck is presenting, and Ramu will be introducing Dr. Andrew Beck in a little bit. But briefly to introduce HAPSA-Nepal, and as you already are all familiar, we have the mission to respond, empower, transform, and save lives. And we have been carrying out different activities in Nepal, including mostly focusing on education and training. One of them, some of the highlights that we have is the Nepal Lifesavers Program, pre-hospital trauma and emergency care, Poison Center Collaborative, and point-of-care ultrasound trainings that we've been doing. And the idea is that we are trying to reduce the number of preventable deaths or adverse events from potentially treatable conditions that could have been addressed prior to even arriving to the hospital. And we have a lot of educational content available on our website online. You can scan this QR code to get to these webinars from our previous sessions. Every month, we also I want to remind everyone that we also conduct a poison center, like toxicology webinar as well. And the content from prior sessions are also available on the website. And we do want you to stay connected with HAPSA-Nepal, and there's the information for joining us. You can find our phone email address there. If you need any support for poisoning, the Poison Center is always available, and you can call this number from anywhere in Nepal to be connected. So let's get back to today's topic, and we're talking about Andrew Beck. And I want to invite Ramu Karel, who is the president of HAPSA-Nepal, founder of HAPSA-Nepal as well. So he will take over and he will introduce Dr. Andrew Beck for today's session.
All right, thank you, Dr. Subarna, and thank you everyone for joining. And my name is Dr. Ramu Karel. I'm also an emergency medicine physician here at Brown University and the founder of HAPSA-Nepal. Our HAPSA team is also here. So thanks to everyone. And we're really excited to have this new series added to, something that Dr. Subarna has been doing for a while, but new to us, added under HAPSA. And we're really excited for our sort of first collaborative webinar as a part of this that focuses specifically on emergency care. And today, I am so excited to introduce a really good friend of mine, as well as an expert in the topic, who has been doing tremendous teaching around the world, and he's one of the best teachers that I personally know. So I know that this session is going to be fantastic. Dr. Andrew Beck, he is a fellowship-trained, board-certified emergency physician, and he's an assistant professor of emergency medicine at Brown University. Dr. Beck has been in practice for 9 years in both United States and abroad. He has many experience in low resource settings, especially focusing on Africa. I personally have done some work with him in Rwanda, where he teaches emergency medicine. He also focuses on airway management, DKA, as well as pulmonary embolism research in low resource setting. He has focused on medical education and has done many novel teaching methods in emergency medicine around the world, and including video conference modalities. So this is really exciting to have him here. He has had many publications in global emergency medicine as well as education literature. Outside of clinical medicine, he is a parent of 2 beautiful children, and he loves running, hiking, playing music, and he's a great singer as well. So I am really excited to have Dr. Beck join us today. And please, without any further ado, Dr. Beck, the floor is yours. Please share your slide and let's go ahead.
Thank you, Dr. Curl, though I can't promise any singing today, but we'll go right ahead.
Hear some.
We'll go right ahead and get started. Let me share my slides here. I would like to say before we get started that as many of you, if not all of you on the call, have experience working in the kind of settings that we're going to be talking about or are working in them directly, I thoroughly encourage and welcome participation during the discussion from anyone on here, because the more that you contribute, the richer the discussion will be for everybody, especially in considering the challenges of settings where there might be fewer resources or challenges in transporting a patient or obtaining medications or diagnostic testing. Let me go ahead and get the slides going. Okay, can everybody see them?
Yep.
All right, very good. So we'll get started with talking about the diagnosis and management of pulmonary embolism in adults in settings where we have limited resources available. So first, I have no specific financial disclosures related to this discussion, and we'll begin with a case-based discussion. For starters, we have a 67-year-old female who is short of breath at rest and with exertion. Her symptoms began approximately 2 days ago, and she presents with sudden onset dyspnea, mild right-sided chest discomfort, and a dry cough. She has a history of hypertension and breast cancer. Her initial vital signs are notable for a heart rate of 112 beats per minute, blood pressure of 100/50, respirations of 28 breaths per minute, and she is saturating 89% on room air. She is in moderate respiratory distress, but speaking full sentences, and her lungs are clear. She does have right lower extremity edema and erythema. So in these initial moments, do we have any initial thoughts about what we should be doing for this patient and how we could be caring for her, what we should do right away in terms of the immediate stabilization and management for a patient like this, especially if we are seeing this patient in a place with very limited diagnostic and treatment skills or treatment abilities? Anyone have any thoughts on where we would begin?
So I work in a relatively not very resource limited, but it's a remote freestanding emergency department. So anything that could potentially become critical rapidly, I just stay on alert all the time. And for someone who is presenting with respiratory distress, I would do the same things that I do with any sick person: assess their airway, breathing, and circulation, for as presented in the slide. But I would be doing things at the same time while assessing the patient. I would put her on some oxygen. I would be listening to her chest. I would be, getting more physical exam as much as possible. And if there's family members who can provide more context about how long this has been going on for, I'll be asking those questions at the same time and get additional history while, stabilizing the patient, getting IV access, getting an EKG if available, trying to get a chest X-ray versus getting the portable ultrasound to the bedside.
Wonderful, very thorough. For me, one of the first things to do, and anyone who's having difficulty in breathing, especially if there are no other resources available, is to start the patient on oxygen. Even if you don't know what their pulse oximetry is, there isn't going to be a major consequence or harm associated with that, and it could be immediately stabilizing and life-saving. So let's take a look and go through this a little bit. So first things first, we could be doing that using a nasal cannula, using a mask. We could, if we have it available, use high flow oxygen via nasal cannula. If we have things like CPAP and BiPAP available, these could be immediate stabilizing resources for this patient as well, while we are working to further diagnose and treat the patient. Do we have any thoughts on what a differential diagnosis might be for this patient? And to be very clear, this is not a mystery. This is not supposed to be anything tricky because the talk is about pulmonary embolism. And so, for me, right away, a top differential diagnosis in an older person with a history of cancer who comes in tachycardic with a swollen leg, clear lungs on exam, and slightly hypoxic, pulmonary embolism is a prime differential. But do we have any other possible differentials that we're considering?
So I would consider other like common scenarios as well, including acute exacerbation of CHF, pulmonary edema, pneumonia, COPD exacerbation, those like top common differentials. And then also I would consider is this ACS? So we would get get an EKG right away as well. And yeah, those common ones.
Mhm. Yep. Yes, pneumonia, tuberculosis, some are the ones that come to mind for me. Pneumothorax. Even though some of those differentials wouldn't perfectly fit the situation itself, when we're considering critical presentations of difficulty in breathing, we should still remain broad just to make sure that we don't prematurely overlook a critical differential diagnosis. And so if we have the availability of these things, ideally, building a strong clinical assessment in terms of the patient's examination and history, and if available, some sort of lab testing, some sort of imaging testing, if we have that as an option to us. And further, there might be some bedside tools that we might have available. These could include things, for example, EKGs. These could include things like ultrasounds. If these things are available, these would be where I would be beginning. If I didn't have all of those things, that's fine. I will use whatever resources I have available to try to narrow and refine my differential diagnosis to get a solid idea of what is happening with the patient. So in resource limited settings, especially when we don't have things available, if we don't have things like CAT scans available, if we don't have X-ray machines easily available, your clinical history, your clinical examination, your vital signs, and the patient's prior history are going to be the prime and most important things in actually forming your differential diagnosis. If you do have more advanced diagnostic capability available, you might be able to spend slightly less time in terms of performing a thorough history and examination. However, if you have less available, those aspects of this become critical because the patient that we are talking about right now has a very classic presentation for a pulmonary embolism. Older, history of malignancy, vital signs that support the diagnosis with tachycardia and hypoxia, and an exam that supports it as well with suspicion of a deep vein thrombosis with unilateral calf swelling and clear lungs on examination, whereas the majority of the other conditions that cause respiratory distress in some way will have some abnormal breath sound. Pulmonary edema, pneumonia, pneumothorax, you should have asymmetric breath sounds. There are other things that you can find on a clinical picture to support those other diagnoses. If you have things available, for example, lab testing, checking metabolic panels and complete blood counts and blood gas analyses, troponin testing, D-dimer testing, X-ray or CAT scan, and electrocardiogram can all be supportive adjuncts in your diagnosis. And then point of care ultrasound becomes very valuable if you have one available, as ultrasound machines tend to be a little bit more affordable and often more available than more advanced diagnostic imaging such as CAT scans. Here's the patient's electrocardiogram. We do have that available. Does anyone notice any particular patterns here or see anything specific that could clue us in as to what the patient might or might not be experiencing? I have one person on the chat who says inferior wall MI. Anyone see any other findings here that could suggest something particular?
Yeah, so there are other comments, S1, Q3, T3, someone also said S1.
Q3, T3.
Yeah, we see a couple of findings here. First, the overall rate is tachycardic, and then we see a strain pattern that we call S1, Q3, T3, where we have an S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. Those findings suggest an axis of the EKG that is favoring strain of the right side of the heart. The differential diagnosis of an inferior wall MI is something worth considering in a case like this as well. However, you wouldn't necessarily see that S1 in lead 3, and you might see elevations or depressions of your ST segments in 2 and AVF, which we really don't see. We do see some specific in lead 3, though. This is a specific EKG pattern. In terms of diagnosing pulmonary embolism, Tachycardia is the most sensitive EKG pattern, so you will not necessarily see the S1 Q3 inverted T3 pattern that we see here, but you might see tachycardia. That is actually going to be your most common ECG finding beyond simply a normal ECG in the management and diagnosis of pulmonary embolism. Now, let's take a look at point of care ultrasound, because in respiratory distress with no other resources, point of care ultrasound can be extraordinarily valuable. This is a rapid bedside tool that can quickly differentiate your causes of dyspnea. It complements your chest x-ray, and for many conditions, especially pneumothorax, pleural effusions, and pulmonary embolism, this is far more sensitive than a chest x-ray is for all of those conditions. It's actually a much better diagnostic tool. A lot of us become more familiar or comfortable with simply ordering a chest x-ray. However, ultrasound is much more valuable in this moment. It guides your immediate management. For example, you will find specific findings on ultrasound as well that can narrow, if not completely resolve, the differential diagnosis for you. For example, if you see B lines, this is an immediate indication of pulmonary edema and CHF. If you see consolidation, this is an immediate indication of pneumonia. If you see absence of lung sliding, and we'll look at some examples of all of these, or something called a lung point, this is immediately diagnostic of a pneumothorax. If you see an enlarged right ventricle, this can be diagnostic of a pulmonary embolism. And if you're concerned about your patient's volume status, in other words, whether their tachycardia and or hypotension is explained by a competing non-cardiopulmonary differential, you can assess whether they are hypovolemic immediately at the bedside beyond exam findings such as skin tenting or delayed capillary refill or dry mucous membranes. You can look at the fluid status in their inferior vena cava right there. So if you take point of care ultrasound and combine that with your clinical context, and this is one of the keys when we're doing this with limited resources, we start with a ranked order differential diagnosis based on the likely diagnoses the patient might have, and then we complement that with our POCUS testing, point of care ultrasound, and our lab testing or imaging testing as available. This can alter the probability of our final differential diagnosis. This allows for faster and safe decision making, especially if we have relatively few resources. Because when we're talking about pulmonary embolism in particular, the consequence for being wrong about that is first allowing a critical diagnosis to persist. But if we assume the diagnosis is present and then treat it incorrectly, when it's not there, we could be giving the patient a blood thinning medication that could have consequences as well. So we want to try to increase the likelihood of a correct diagnosis and minimize the likelihood of a false positive. We have several different transducers that we can use. And we'll look at some images that are purely for teaching. These are not related to pulmonary embolism yet. They're related to competing differential diagnoses. Here, our image on the left is a static image. This shows what a B line is. When we scan the patient's chest, we see hyperechoic lines that extend from the pleura down through our field of scanning. These are known as B lines on an ultrasound, and these are a sign of a pulmonary interstitial syndrome, for example, pulmonary edema. Let's look at how these look, what we'll see in real life here. You see them extending all the way down from the actual pleural line. They're otherwise known as comet tail, as they look like a vapor trail off of a comet, is the most common other description for them, consistent with pulmonary edema. This would be an unlikely finding in pulmonary embolism unless you had a separate diagnosis present as well. This would not be expected in that situation. This next image shows what consolidation looks like in the lung. You get mostly a gray and black field with a mixed picture of fluid and air. Your dark black areas are fluid, your white areas are air or reverberation artifact from air getting in the way in the ultrasound itself. This would be more consistent with aspiration or pneumonia or atelectasis. This next image reveals what is called lung sliding, where we see our pleural interface, which is this bright white line just near the midsection of our screen here. That is your pleural and your peripheral, your parietal and your visceral pleura sliding against itself as the lung moves. This is a normal finding, suggested that you do not have a pneumothorax present. If that line is absent, and you don't see this shimmering going across as the lung slides, that could be an indicator of a pneumothorax. We'll take a look at a next slide for that. Notice here, to the left of our image, your pleural line is just bright. You don't see it shimmering as it moves. And as the patient breathes, you see an actual lung moving in the right side of the image. This is consistent with a pneumothorax on ultrasound. I'm going to skip over this one for now. This slide is suggestive of what we might see with a pulmonary embolism. Can anyone tell us what we're seeing here?
It is a D sign, which is called the collapsing of the left ventricle and the dilatation of the right ventricle.
Yes, because it looks like the right ventricle, which should normally look like, should be the shape of a crescent, and the left ventricle should be circular. That shape has changed because the right ventricle has enlarged due to pressure overload. The right ventricle no longer appears to be a crescent. It actually looks like a letter D in reverse. And the left ventricle, which should be circular, is now being crushed and looks like a letter D in the normal orientation. That's what we're seeing in the upper left image. What are we seeing in the lower right image? What is that?
So in the lower right image, the right ventricle seems to be really big compared, like almost equal or even larger than the left ventricle. And I think at the lung apex, there's discrepancy between the movement of the heart apex and cardiac apex and the wall of the free wall of the right ventricle.
Yeah, absolutely. Your ratio in terms of the width of your right ventricle to your left ventricle should be 1 to 2. In other words, your right ventricle should be about half of the width of the left ventricle when viewed in an apical four-chamber. If they are the same, or if the right ventricle is larger than the left ventricle, this could be consistent with a pulmonary embolism from increased pressure in the pulmonary circuit. There are other things that can do this. For example, chronic obstructive pulmonary disease, pulmonary hypertension. This one isn't necessarily specific, but in the right context. In a patient who has no history, who has no history of pulmonary hypertension, who has no history of sleep apnea, who has no history of any sort of lung disease at all, and presents with acute dyspnea with signs of a deep vein thrombosis or risk factors, this would be very likely consistent with strain from a pulmonary embolism. This shows that in greater detail. The right side of the screen here, labeled letter B, is how the left ventricle and the right ventricle should look. They should be round on the left ventricle and crescent-shaped on the right. Whereas image A on the left side of the screen shows that the right ventricle is enlarged and the left ventricle is collapsed. This would again be consistent with strain in the pulmonary circuit on the right heart and consistent in the right context with a pulmonary embolism. If you have a CAT scan available, you can often visualize, if you have CAT scan with contrast, thrombus within pulmonary circulation, whether it's in the right ventricle or the main pulmonary artery, as in this case. The arrow here, the red arrow, is pointing towards an area of filling defect where blood mixed with contrast is not able to fill into this area that is gray, and that's because the gray area is reflecting a blood clot that is stuck inside of the vascular space there. And then the yellow areas are showing us additional areas of blood clot in the right pulmonary and left main pulmonary artery. You can also see an area of unlabeled blood clot in what is likely a left superior lobe pulmonary artery just to the right of the actual main pulmonary artery right here. So now, based on that evaluation, we suspect our patient has a pulmonary embolism. So management of a pulmonary embolism depends on several things. It depends on how severe it is, and it also depends on what resources you have. First, we want to make sure that we're optimizing our patient's airway, breathing, and circulation status. So in terms of our airway, in general, a pulmonary embolism is not going to compromise your airway unless the patient has another problem present at the same time. However, it can compromise breathing in terms of oxygenation. And so make sure your patient is on oxygen, ideally titrated to a minimum of 94 to 96%. If the patient is in severe respiratory distress, you could consider whether CPAP or BiPAP might benefit the patient in terms of their oxygenation and helping to optimize their hemodynamics in terms of preload and afterload. Though depending on the position of a blood clot and how large it is, hypotension could hypothetically be made worse if the patient is hypotensive when given CPAP or BiPAP. So just be aware, if you're starting them on that, you might worsen their hemodynamics. If your patient is hemodynamically unstable, this is a critical situation with a pulmonary embolism. And we should consider if we have medications such as thrombolytics that can break up a pulmonary embolism, and consider the use of vasopressive medications if we have those. It's commonly taught in resource-limited settings that if you have a patient who is hypotensive, you should treat them with fluids. This is an exception to that rule. If you give a patient with a pulmonary embolism fluids, assuming the patient is already euvolemic and has a normally functioning heart, fluids can actually worsen a patient with pulmonary embolism. And that is because they increase the strain on the right side of the heart, which further compromises cardiac function and can result in arrhythmias and further hemodynamic decompensation. Be very careful with giving fluids to patients who are hypotensive and in whom you have a high probability of a pulmonary embolism. Giving patients blood thinners is an appropriate choice. If you have them available, heparin, enoxaparin, or oral anticoagulants, you can choose any except for warfarin. Remember that warfarin temporarily makes patients hypercoagulable until it has had a chance to adjust, until the patient's body has had a chance to normalize its production of clotting factors, such as proteins 2, 7, 9, 10, and protein C and protein S. When we start patients on warfarin, we have to bridge them with either heparin or enoxaparin to prevent a temporary state of hypercoagulability. So if your patient is thought to have a pulmonary embolism, you can start them on anything but warfarin as long as, or if you have warfarin available, make sure you have heparin or enoxaparin also available. If your patient is unstable and you have it available, a thrombectomy is another possibility for something that can be performed, assuming that that is within the capability of the hospital that you're working in or available with reasonable transfer. So in this case, our patient is treated with oxygen. We begin the patient on heparin, and they have a large blood clot, and we transfer them for a thrombectomy and ultimate admission. So now, to make this a specific discussion about Nepal and the resources available, I did some background work here to get some information here in terms of the current understanding of the management of pulmonary embolism in Nepal. And, I've got 3 papers that we're going to talk about very briefly because ultimately I want to talk about a lot of this with you because your experience is actually as, if not more important than any of the research that's being published for single centers. Because a lot of the work that I could find, at least within the last 10 years in Nepal, most of the studies on the diagnosis and management of pulmonary embolism were single center studies. Some of this work was very good, and it gave a lot of information about clinical presentations and management and outcomes of pulmonary embolism. Across this paper here, this next one, clinical profile management and outcome of pulmonary embolism in the Heart Center in Kathmandu. And finally, this paper, clinical profile management and outcome of patients presenting with acute pulmonary embolism at a tertiary level cardiac center in Nepal. All of these papers highlighted a couple of things in particular. First, the morbidity rate of pulmonary embolism in Nepal remains relatively high, and the mortality rate remains relatively high. A lot of these papers indicated that there was still approximately a 10% mortality rate for this condition. Secondly, all of the papers highlighted that CAT scans are not always available for diagnosis. They also all highlighted that a lot of the patients experiencing pulmonary embolism might not be able to afford novel oral anticoagulant medications or be able to afford transfer to a tertiary care center, especially if they're coming from a smaller area of the country. And they might not have access to appropriate follow-up testing to make sure that they are getting better. What I just said, does that fit with your understanding of the diagnosis and management of pulmonary embolism? That is to say, sometimes we're not diagnosing it completely precisely because we might not have a CAT scan available. And sometimes we might not be able to treat it in the most optimal way because of either availability of or affordability of medications. Does that fit with your understanding as practitioners in Nepal? Dr. Adhikari, you're on mute.
So Dr. Kamal Thapa should be on the conversation. I invite him to start with to comment on that. And one of my friends, Dr. Pradeep Tiwari, he works as a critical care physician in the civil hospital in Kathmandu, Nepal. He may be able to weigh in as well. He should be in the conversation as well. Kamal, if you can comment on that, like how frequently would CT angiogram or CT scan be available, and what level care center would have that, and also like if you could talk about the new oral anticoagulants, including apixaban, rivaroxaban, are those in common use in Nepal at all? Can people afford those? How expensive are they?
Subarna, yeah. So at the center I work at, we investigation wise, we do CT pulmonary angiography routinely for anyone we suspect. Of course, in addition to clinical suspicion, ECG, and especially POCUS findings, CT scan is available only in major tertiary care centers and in the out of Kathmandu hospitals with the tertiary care centers. CT is not available everywhere. We have been using enoxaparin, and also these days the very good oral anticoagulants are, I think, equally effective. I have a question to Andy. Are the oral anticoagulants equally as effective as the injectables or the heparin? That's my question as well. So this season, I also work at the travel medicine center where we see people coming from high altitude, and we diagnose a significant number of dyspneic patients with pulmonary embolism. And we know it's very underdiagnosed in most of the hospitals in Nepal. Yeah.
Yes.
So Pradeep would add some different perspective from ICU point of view and from a government hospital perspective.
Yeah.
Is Pradeep there? Dr. Pradeep Tiwari.
Yes, yes. So, yeah, I agree to Dr. Kamal. So we right now in the Kathmandu in the tertiary care center, we routinely thrombolize our patients. So that's like a standard of care, but we don't have facility for let's say catheter directed thrombolysis. So that's not readily available yet. We manage our patient with NOAC, and yes, that's readily available. I think that's available all over Nepal. But the thrombolysis is pretty much limited to some centers in the Kathmandu and very few centers outside of the Kathmandu.
So there are also, yeah, right. There are also comments in the conversation chat that says like P is underdiagnosed in Nepal, very less considered in differentials. Newer anticoagulants are available in major cities, but the availability and cost of the thrombolytics is also a major issue. So do you feel that pulmonary embolism is less often considered as a differential in Nepal? Because that's what I felt like. I went to medical school like first residence there. So we never thought about pulmonary embolism as a big deal, and I think that was kind of what was lacking in our practice. We didn't think of it as being very common, but once I came here, I started feeling like, oh yeah, it could happen to anyone, so we should consider that all the time. So do you feel, Kamal and Pradeep, question for both of you, do you feel like pulmonary embolism is not very often considered as a differential, and we think about other more common things first? Is that your experience too?
Yeah, that's very true, Subarna, because like when patient came to our centers like 4 or 5 days after onset of dyspnea, usually they are diagnosed with the pulmonary embolism. So I think on the initial point of presentation, we feel like the patient should have been investigated for the pulmonary embolism. So that's quite common to get a patient after a week with at least submassive PE to come to your ER.
Yeah, that's a very good context. And the three papers that I found here also commented on the suspected underdiagnosis of the condition in Nepal as a whole. Um, the one of the questions that was also asked by Dr. Kamal was the comparability of oral anticoagulants with IV anticoagulants. There is certainly a difference when you're talking about thrombolytic medications. However, available data that we have anyway shows that whether you're treating a patient with heparin, enoxaparin, apixaban, rivaroxaban, or warfarin after bridging with heparin or enoxaparin, that the ultimate data on resolution and safety of those things is about the same. However, it is much easier to diagnose, or sorry, to treat the condition using oral anticoagulants, for example, apixaban and rivaroxaban, than it is to treat with subcutaneous heparin or enoxaparin, IV heparin, or warfarin, especially because warfarin requires such a degree of laboratory monitoring and dietary adjustment that is really not required with the oral anticoagulants of apixaban and rivaroxaban. However, if the patients cannot afford the medications, then we manage them based on what they are able to do. All right. Let's see, I think everything else in the chat has thus far been reasonably well addressed. Dr. Lokesh mentions there's a lack of guidance on D-dimer testing as well. Yeah, we can talk about that, and we're going to in just a moment. All right.
And I think there is some folks hopefully joining from very rural hospitals. If you guys can chime in also, that would be really helpful because I know there's few folks from Bailpata Hospital, Bailpata Provincial, where, it's such a big challenge compared to Kathmandu because you really just have to work on transferring and diagnosis is all clinical. So it would be good to hear from you guys from rural areas too.
Agree with that, Dr. Carell, because reality is when you have a lot of resources, especially lab testing and CAT scanning, pulmonary embolism is relatively easy to diagnose. And if you have the money to manage it, it's relatively easy to manage it. However, if you have nothing, it's a diagnosis that you cannot exclude, and it's difficult to decide when you should transfer someone to have it diagnosed or treated, or when you should simply consider empirically treating the patient if the likelihood of competing diagnoses is very small. And so that's a very valid conversation when you have limited resources. I also want to call everyone's attention to a comment that was just made in the chat by a participant named Kamal. It states 15 milligrams of rivaroxaban costs 125 rupees per tab, which is less than $1. Just curious, does anyone know how much it costs in the United States if you don't have insurance?
I'm going to assume $500 per tablet. I don't know.
Per tablet, Ramu. Oh my God, we should export this tablet to US to do some good.
Believe it or not, most of these get manufactured here and get transported over there, and they start costing less after the transport and manufacturing cost is added in other countries than they do here. So it's unbelievable.
Yeah, in general, 1 month's supply of apixaban without insurance costs around $800. So that would be what if Ramu, do you know the exchange rate off the top of your head?
Yes, 145. 145.
To 145 to 1?
Yeah.
Okay, so let's see, 8,000, 80,000, so 125,000 rupees would be the cost of 1 month's supply of apixaban in the United States.
Right.
Right. Yeah. That's obviously impractical. Okay. Let's go on to a couple more slides here. So we've already talked about some of these sorts of things, but some of the discussion that I want to have in terms of the availability of resources and tests and treatments, when to admit someone, when to transfer someone, how to manage them, when to do it inpatient or outpatient. Oxygen we've discussed adequately, so we'll skip over that. Common pitfalls or challenges, that is to say, risk of misdiagnosis, use of fluids, we've discussed a little bit as well. And here's a number again of these questions that we can start tackling as a group here with the remaining time we have left. Whether that relates to limited resources, what's your best diagnostic strategy, which I think we probably should go over. How to prepare and optimize patients for transfer is something that we can discuss. Using well evidence-based diagnostic scoring systems. There are many of these things because PE, pulmonary embolism, is a relatively challenging diagnosis, and I'll clarify what I mean by that in just a moment, but We can talk about special cases, pulmonary embolism in pregnancy, choice of anticoagulation, and then who can be managed outpatient. I think those are probably some valuable things to consider for this conversation. To briefly touch on what I was just saying about pulmonary embolism being a challenging diagnosis, the hardest part when you have resources, when you have CAT scans and labs available, the hardest part is deciding who you test for it. Because hypothetically, every patient who has chest pain, shortness of breath, or leg swelling could have a pulmonary embolism. We don't have excellent ways of excluding the diagnosis. We can only say it's either more or less likely. And it's also common enough that we know it co-presents. It can present jointly with other causes of chest pain and respiratory failure as well. And so we often run into a challenge, especially in the United States, of who do we test? Do we simply test everybody who comes to the emergency department or to your hospital with chest pain and shortness of breath? Or do we selectively test some people? And as a result, there's been a lot of research into really who are the higher risk patients and who are the lower risk patients for this condition. We can talk about that, but I'd like to hear what of these areas might be the most valuable for us to talk about from your perspectives as working in country.
I think all the points.
So why don't we start with the best diagnostic strategy? All right, so with that in mind, as we mentioned, if you have labs and CAT scan available, that is unquestionably the best diagnostic strategy because that will be both sensitive and specific. But if you don't have it available or if your patient can't afford it, then what do you do? So we actually use this even in my hospital, which is well resourced compared to a lot of the places that I've practiced. We actually use a diagnostic strategy to do this simply because we have decided that not every patient needs a CAT scan, and they shouldn't have to afford a CAT scan if they don't really need it, and they shouldn't be exposed to radiation if they don't really need it. So let's talk about some strategies for how you can diagnose this without CAT scan. So first, as I said earlier, and I'll move on to this page here. Actually, I'm going to back up from this for just a moment because I want to talk and not have the slide be read right now. First, your history, your exam, and your clinical suspicion of pretest probability should guide your diagnosis of the condition. If you have a patient who is 18 years old, who does not have cancer, who is healthy, who has been ambulatory, has had no recent surgery, does not have leg swelling, does not have calf cramping, has shortness of breath associated with a fever and a productive cough with sputum for 2 days, what do we think the likelihood is that that patient has a pulmonary embolism?
Very low.
Very low.
Yeah.
Right. That patient likely has either acute bronchitis or acute bacterial pneumonia, maybe tuberculosis, depending on the situation. And the likelihood that that patient has a second problem is low, especially if the patient's heart rate is below 100 and their oxygen status is normal. So in a case like that, where you have a patient who has a very low pretest probability, first, you could simply say, pulmonary embolism does not seem clinically likely, and we will monitor the patient and treat them for their current condition. If they worsen, we will diagnose or attempt to diagnose the condition later, give them time to see if they heal from the reason for which they are presenting, which appears to be an acute infectious respiratory illness, and do no further workup right now for pulmonary embolism. This is the first point on a diagnostic algorithm that is commonly employed when we have relatively low resources. That is to say, if you have a very low pretest probability and the patient is negative on a scoring system called PERC. PERC stands for PE rule-out criteria. If you're not familiar with PE rule-out criteria, do a Google search and find it because PE rule-out criteria can be very helpful in patients who are very low pretest probability for the condition. It can allow you to say with medical confidence that the patient is unlikely to have a pulmonary embolism. In fact, the scoring criteria actually make it less than 2% likely that the patient has a pulmonary embolism. That's very reliable. That's trustworthy even. Even in my country where there is high medical legal risk to being wrong about this, we use PE rule-out criteria as the standard of care. If you have a patient who has a lower pretest probability, but not very low, that is to say, They don't have cancer. They don't have signs of a deep vein thrombosis. They are not tachycardic. They are normoxic, but they do have pleuritic chest pain, and they are 45 years old. They do not have any active cancer. They've never had a blood clot before. You can exclude them without the need for imaging using D-dimer testing. In this case, you can use a scoring system such as Wells criteria to guide your evaluation there, or the Geneva criteria, which help estimate your likelihood of having a deep vein thrombosis or a pulmonary embolism. And if the patient has a low likelihood, you can exclude them by ordering a D-dimer test. And as long as that test is negative, you can again clear them from having a pulmonary embolism. So this assumes you have access to that test. And if you do, that's great because it's an excellent test. But if you do not, then some of the next things that you could do would be bedside ultrasound to see if you find any evidence of right side heart strain or see any evidence of a deep vein thrombosis or blood clot. And that combination together could help you say the patient has a low to moderate pretest probability and a negative D-dimer, therefore I can exclude them from having a pulmonary embolism. For what it's worth, D-dimer is a sensitive but not specific test. D-dimer can be positive falsely, and it often is in cases of trauma, inflammation, infection, or pregnancy. In those cases, if it is very slightly positive, you might have to make a judgment as to whether or not you can still consider the patient. You can clinically delay testing for the patient. If your dimer is positive, you cannot say with confidence that they don't have a pulmonary embolism, but you could say, I think the dimer is positive because the patient has pneumonia and I will treat them for that first. Okay. In the high pretest probability case, and this is actually where a lot of the conversation should probably progress to, because if you are in a center that has limited resources and you have a patient who you think is high pretest probability, you have to make a decision. And that decision has to be, do you empirically treat the patient, even though you can't confirm the diagnosis? Do you empirically treat the patient, or do you transfer them for definitive diagnosis and treatment? So those of you who work in centers where that might be the case, what are your thoughts about that? What would you do if you had a patient who you thought was high pretest probability, you don't have a CAT scan available, you don't have a formal ultrasound available? Do you transfer them, or do you treat them and keep them there, even though you don't know the answer for sure?
I would probably treat.
Empirical treatment.
Okay, what would you do?
Treat and transfer.
Okay, so we have a mixture of input here. Someone talk to me about the decision to treat. Why would you treat and not transfer? Or why would you treat and transfer? Talk to me about the logic that would go into those decisions, because they're all potentially correct answers. In fact, this is all judgment, and this is where your skill as a doctor comes into play here, because you have to decide what's the best thing to do for this person. How would you decide who you treat, who you transfer?
I think treating should be the first priority if you have a high probability before transferring, because if on the way, if it's an evolving P and then can have a massive cardiac arrest or something. And there is definitely, we need to have an evidence that to continue the anticoagulants, we need to have an evidence, some sort of evidence that this patient has a P or something. So if we need to discontinue the treatment or to have to know about the other differential diagnosis as well, we need to definitely transfer for a CT. So I think treat and transfer.
Okay. Yeah, that would seem a reasonably safe approach. Do you have patients who would refuse transfer, or do you have patients who you could never practically transfer because of where they are?
Absolutely. A lot of rural areas, Andrew, like, people can't afford, is the main reason that people will refuse transfer. So that is definitely the case. A place where we work in Far West in Bailpata, that is a case that we see almost on a daily basis. If there's someone here from Bailpata, I would love your response on that, because that is a challenge we have faced many times. And I'll add on this that one of the decision points that can be used, that we have used in other places too, is almost all hospitals have chest X-ray and EKG available. Now, these are not used to diagnose PE, but these can tell us if there is something else, right? So if you use that and you don't have any signs of anything else, that might give you more reason to say, you know what, PE is now more likely because I don't have any other cause of this, and that might tell you to treat there, right? So that these two are, I mean, these two are mandatory tests that must be done to all dyspneic patients, but make sure that you're utilizing these very, very much.
Right, that's absolutely right. If you can list your top 10 differential diagnoses that the patient might have, if you can exclude 7 or 8 of them and then, get it down to pulmonary embolism versus pneumonia or versus pleurisy or something along those lines, that would be a reasonable strategy as well, because you have to use some clinical judgment in terms of what the patient could have when you don't have resources available. Another strategy as well is if you still have more than one competing differential, you can treat the patient for more than one thing because there are relatively few contraindications to treating with blood thinners as long as your patient does not have active bleeding, does not have a recent head injury, did not have recent surgery, and isn't in renal failure. There are actually relatively few contraindications to giving the patient a blood thinning medication. And so let's pretend that you still have on your differential a pulmonary embolism and you still have pneumonia on your differential. First, if you did serial chest x-rays, pneumonia should have an evolving chest x-ray. But if you had to give the patient antibiotics and blood thinners at the same time, that would be safe. If you still had pericarditis and PE on your differential, hypothetically, as long as your pericarditis is not hemorrhagic, giving the patient a blood thinner would also be safe. That said, if you did serial labs and serial EKGs on these patients, you would see changes that would argue for one of these diagnoses over another. And that would also tell you which treatment to then continue or which one to get rid of. Really quickly in the chat, Dr. Das has asked a couple of questions. One is how sensitive is a chest x-ray for PE? Dr. Adhikari mentioned not sensitive at all, and yes, that is true. Eventually, it can become specific, but only specific if your pulmonary embolism is in a position that allows you to see a lung infarction. Otherwise, chest x-ray is generally normal in PE or simply diagnostic of other competing differential diagnoses. So if you have a patient who is tachycardic, hypoxic, and short of breath with a normal chest x-ray, no pneumonia, no pneumothorax, no signs of pulmonary edema, no signs of tuberculosis, PE becomes very likely because you should see a normal chest x-ray. And then the next question that was asked was, how quickly can we see x-ray change in a patient with PE? And the answer is, as Dr. Lokesh mentioned, unless you have an infarction, you will not. It will not change. Dr. Sudeep mentions you can see a Westermarck sign. That is hypothetically true, but you have to have a very high quality x-ray to be able to see a Westermarck sign. And you have to have a blood clot in an area of the lung that is large enough to actually compromise blood flow to a regional lung lobe. You won't see a Westermarck sign if you have a central pulmonary embolism or a far peripheral pulmonary embolism, at least not reliably. All right. So yeah, great discussions there. In some of these other points, what would be the next most valuable for you guys, or at least maybe Dr. Atakari or Dr. Carell? What do you guys think would be perhaps the more valuable signs or valuable next questions here from what we can talk about?
I believe the last one, like who can be discharged or managed outpatient, like do all of these patients need admission? I think that'd be an important one to discuss.
Right. Yeah. All right. So tell me, of those of you who work there, how many of these patients do you manage outpatient and how many do you manage inpatient, and what are you using to decide? And then we can talk about some more criteria you can use to actually make that decision.
So I work, like I said, in a freestanding emergency department. Any patient that I need to admit is a transfer, and oftentimes, it's like a 2 to 3 day wait before they can even get a bed. So when I can, I will try to see if I can talk to a specialist and then see if they are, not recommending any further interventions. And if this patient is a relatively younger patient with not too many comorbidities, not needing oxygen, and not having any abnormal vital signs, no active chest pain and things like that, and if they are able to follow up reasonably, then I feel comfortable discharging them. If this is someone relatively older, obviously if they are needing supplemental oxygen, and if I do not feel that they have adequate capacity to follow up outpatient, then I don't really feel comfortable discharging these patients home. I know that we could use certain criteria like PC score and this like that. I don't really use it all that often, but I think that's what's recommended.
Right. Okay. Yeah, to some extent, this is clinical judgment, and a lot of it is circumstantial, and some of it there are evidence-based scores that we can use. So first, in terms of your judgment, if you consider the patient in front of you and consider their overall severity, for example, are they severely dyspneic, increased work of breathing, tachypneic? Do they have tachycardia, tachypnea, hypoxia? Are they older? Do they have a number of comorbidities, especially coexisting heart disease, lung disease, or renal disease? Do they have any discernible lab abnormalities? Is there any reason that you cannot treat the patient with a blood thinner? These would all be things that would suggest you should admit the patient or transfer them. If you have a patient who is younger, healthier, with normal vital signs, normal oxygen levels, able to understand their diagnosis, able to afford the medications, in many of these cases, you can manage pulmonary embolisms on an outpatient basis, especially if you know that they have a smaller pulmonary embolism and they don't have any abnormal lab work to suggest injury to the heart or strain on the heart itself. There is a scoring system. You'll see these acronyms in the center of the screen here: PERC, Wells, Geneva. PESI, P-E-S-I, is called the PE Severity Index. The PESI score is something that can also be used to guide, using evidence-based medicine, whether or not your patient is safe to be managed in the outpatient setting. Ramu, I don't know if you're able to put a link to MD Calc in the chat on that, but that would be helpful. And that one also lists essentially the same things that we just spoke about, because a lot of severity is based on abnormal vital signs, patient's prior history, patient lab work, patient imaging work where available. This can guide you in terms of who really has to be admitted for management and who can be safely cared for outside of the hospital. In the chat, Dr. Sudeep just asks, can we use troponins for right ventricular strain damage to rule out PE? To rule out PE, probably not, because troponin is also a sensitive but not specific marker. Troponin can be positive for many reasons, and just like D-dimer, just like ultrasound, just like this conversations that we are having, you'd have to consider, is it positive because the patient is having an acute coronary syndrome? Is it positive because of heart failure? Positive because of hypoxia? Positive because of myopericarditis? Positive because the patient just came down off of the mountains and has high altitude pulmonary edema? There are many reasons why troponin could be positive, but if you have a patient whose presentation suggests pulmonary embolism, they have a normal EKG, but a positive troponin, yes, that could be a marker for right heart strain in that context. Dr. Das just mentions, what about prophylactic treatment for PE, for an example in postpartum patients or bedridden patients? Good question. What are some of the common practices that are currently used in Nepal in terms of prophylaxis for PE right now?
And again, this may be a question for people who do some extent of inpatient medicine, like Dr. Kamal and Dr. Pradeep may be able to comment on these. I believe like all ICU patients will actually get DVT prophylaxis, but Kamal, what has been your experience? Do you keep all of your inpatient patients on DVT prophylaxis?
Yes, for the ICU ones, not for others.
Okay. And for our remote rural settings, if there's anyone from, like Rama asked earlier, if there was anyone from Para Hospital, and I saw someone from, I think, Rosua Hospital, do we do any DVT prophylaxis on these patients at all, on all of your admitted patients?
Hi, Namaste. I'm Dr. Sunil Kumar Das from Roscoe Hospital. I am general practitioner and emergency physician. And here we do keep inpatients. We do surgery, and especially in context of cesarean section, standard practice is to give some prophylaxis to prevent DVT. But yet, while referring to our tertiary center, there is no such called practice of giving prophylaxis, even in Prasuti Hospital, even in Parton, even in IOM. With regard to postpartum patients, meanwhile, talking about indoor patient, those patients with COPD or those patients who are bedbound, who are who tend to stay in the hospital for prolonged period of time, there is a practice of giving prophylaxis anticoagulants. So I hope in Western countries there is a practice of giving a prophylactic anticoagulant for postpartum women also. So I just want to know about that. Thank you.
Yeah, we routinely give DVT prophylaxis to several classes of patients in the United States anyway. Most patients who are admitted, especially if they are bedbound, receive prophylaxis against a DVT. If they are admitted and able to ambulate, walk around the unit, move their bodies, they may not require it, especially if they can simply get up and mechanically stretch their legs. However, almost every patient who winds up in an intensive care unit, nearly every post-surgical patient, and especially those who are bedridden, will receive some type of prophylaxis against deep vein thrombosis. The practice here for postpartum is a little bit different. It varies again based on the patient situation, but not every postpartum patient receives deep vein thrombosis prophylaxis, especially if there's a risk of postpartum hemorrhage, which remains a common problem pretty much all over the world, whether you're in a resource center or a non-resource center. We generally use subcutaneous heparin or subcutaneous enoxaparin at lower doses for prophylaxis when we're giving a patient pharmacologic prophylaxis. Unless the patient is already on a blood thinner for other reasons, in which case we simply allow continuity of whatever blood thinner they're already taking.
Another scope of using prophylaxis is in travel medicine. As I also work at a travel medicine center, we get people with minor risk factor but are traveling a long distance. Then we also definitely do prophylactic.
Mm-hmm. Yep, I traveled to Nepal last in 2017, and I debated giving myself DVT prophylaxis for the airplane because it was a 16-hour flight. I didn't. I just got up and walked around about every hour, but I considered it because that's a very long time to have your feet hung to gravity. There are a number of questions in the chat that are really good as well. One of the questions says, which anticoagulant to give if monitoring is not possible or if there are chances of loss to follow-up. So in terms of anticoagulants, the only anticoagulant that requires consistent monitoring is warfarin. It is ideal if you can monitor a patient who is on heparin or enoxaparin as well. However, giving a patient subcutaneous shots of enoxaparin in the outpatient setting does not necessarily require any particular monitoring, apart from things you can tell the patient. For example, if you have signs of bleeding, you need to represent to a hospital or health center right away. Whereas rivaroxaban and apixaban do not require any particular monitoring. There are some contraindications for them in renal failures, so you should know what your patient's renal function status is, but they do not require serial laboratory testing or any type of serial checking. Dr. Sudeep mentions here, we rarely check for history of calf pain and tenderness in patients, unlike we do for chest pain. How important is it? Dr. Adhikari states, I would say it's important for a routine exam for all patients with chest pain and dyspnea. I absolutely agree with that. When you're thinking about your diagnostic strategy for a patient with chest pain or dyspnea, the kinds of questions you should be asking the patient should be questions that inform your likelihood of the diagnosis being acute coronary syndrome, of it being pulmonary embolism, of it being pneumothorax, of it being pneumonia. And so while you're interviewing that patient and while you're examining them, when you're considering pulmonary embolism in your mind, you should be saying, do you have a history of cancer? Have you been immobilized recently? Have you traveled recently? Do you have any calf pain or tenderness or swelling? Do you have any history of blood clots in your body or in the past? Those things will increase the likelihood of your patient having the condition or help you decrease it in your mind in terms of their likelihood of having a pulmonary embolism. I ask those questions routinely, whether I'm practicing in a resourced or a low resource setting. It makes no difference. Those are always part of my standard questions in exam when I'm working up chest pain. And then a question here, what can be the consequence of PE depending on size, if not managed in a timely way? That's a great question. And so Dr. Carell mentions PEA, and that is absolutely right. So the risk of pulmonary embolism depends on several things. If we're going to talk purely about its size, let's start there because that was the specific question. But the consequences of pulmonary embolism are dependent on the size, the location, whether it's getting bigger, and then the patient's own cardiopulmonary health status. If you have a patient who is young and healthy, they might be able to tolerate a large pulmonary embolism. If you have a patient who is older and has compromised heart and lung function already, then you might have a smaller pulmonary embolism causing greater consequence. But a large pulmonary embolism that is obstructing blood flow, especially if it's obstructing more than 50 to 70% of flow out of the right heart, is going to be shock with hypotension and hypoxia that will eventually compromise the function of the right side of the heart and then blood flow to the remainder of the body, including the left side of the heart. The eventual consequence of this, as a patient's level of hypoxia and acidosis worsens, is that they will begin experiencing troponin. The muscle in the right side of the heart will become more acidemic. There will be electrolyte imbalances in the right side of the heart that will eventually lead to full failure of the right side of the heart, arrhythmias, and death. That is going to be the consequence of a large pulmonary embolism. Smaller pulmonary emboli, especially if they are peripheral and if they're not causing impaired hemodynamic status, there are several possible endpoints in terms of the natural history of a small pulmonary embolism. First, the embolism might simply stop growing. It might not expand further, and the body could simply resorb it, and the patient might do perfectly well. Two, there could be lung infarction where a patient experiences a small amount of hemoptysis, but ultimately heals from that. So again, it all depends on the size and the position in terms of the risk. Until you know the size and position of a pulmonary embolism, you should assume it's larger than smaller. Assume that it is more dangerous than less dangerous. A lot of people believe falsely that a large central pulmonary embolism will cause tachycardia, hypotension, and death. The reality of the matter is most patients who have healthy heart and lungs can tolerate a reduction in blood flow of 50 to 70% from the right side of the heart, and they might actually not show signs of tachycardia or hypoxia yet. You could have a massive pulmonary embolism, very large, that doesn't yet cause symptomatic consequences with your vital signs. And so you should assume that a patient has a big one until you prove they don't, even if they seem like they're healthy and well. Another question here in the chat is, one more concern is determining the timing to discontinue prophylaxis and begin the patient ambulating. What do we do in the USA? So that's quite simple. The soonest a patient can safely ambulate, they ambulate. The faster you can get a patient back to normal physiologic functional status, the better. So if you have a patient who, is, but that said, it does depend on their situation, because there are surgeries and there are particular conditions that a patient might have that would necessitate longer term prophylaxis than shorter term. But let's take, for example, a patient who does not have cancer, who does not have a recent orthopedic surgery, for example, a hip surgery or a knee surgery, who does not have any history of hypocoagulability. The sooner that patient can ambulate, the better, in which case they may not require prophylaxis. But otherwise, this tends to be situationally specific. For example, in orthopedic surgery, they might be on prophylaxis for a longer period of time. It all depends on their risk and the particular surgical risk.
I just want to mention that like we're over the 1 hour time mark, and we just have a few more minutes before we start. Before we need to think about concluding this session. As fantastic as it's going, I think we need to just out of respect for everyone's time, we should just take a couple more questions, and then we should probably start winding up. Any more questions or experiences? Treat a patient once. How long do we need to treat a patient once PE has been diagnosed?
The general standard for that again can vary based on the situation. If the PE is considered unprovoked, that is to say, if the patient has a history of hypercoagulability, or we can't clearly know why they had a PE, the treatment might be lifelong. However, if the patient has had a provoked pulmonary embolism, for example, following an orthopedic surgery, following immobilization, following some sort of infection or long travel, something that we can clearly explain and say they don't otherwise have an increased risk, the general treatment is between 3 and 6 months.
We do have a post-session feedback form, right? Is it going to be shared here in the conversation, or are we going to send out emails?
Yeah, I will. I'm going to share the form right now. So if you guys can all fill this out so we can continue to improve on our sessions, I'll share it right now.
Dr. Beck, thank you very much. This has been wonderful, and I think it was really engaging. Thanks everyone for participating, and mostly from rural places in Nepal, which we like to reach out to and get involved in these conversations. And also, like, it's useful to know what resources are available in Kathmandu or in bigger centers when you are transferring. So I think it's important to have people from all settings participate in these sessions. And I think this was a really engaging conversation. And I think I do agree with everyone's concern that, like, yeah, we don't often think of pulmonary embolism as a common differential, but it's probably happening, and people are probably having long-term comorbidities and dying from it without us knowing and even diagnosing or treating it. So it is more common than we think, and I think it should be considered as a differential in all people, all patients with the right risk factors presenting with chest pain or shortness of breath. I think this was a very wonderful discussion.
It was my pleasure to be here. Thank you guys for inviting me. It was an honor to be invited. Namaste to you and everybody else on the call. Thank you so much for having me.
Thank you, Andy, and thank you, everyone. This is great. We have recorded this. This will be available on our YouTube, the link that we had shared before, but we'll also email you all with the link so you can watch Dr. Beck talk for the rest of your life.
Thank you very much.
Or until you get bored from me.
Thank you, everyone. Thank you, Andy.
Thank you.